The acromioclavicular joint is one of 4 joints that compose the shoulder complex. The acromioclavicular joint is formed by the junction of the lateral clavicle and the acromion process of the scapula. The AC joint is the main articulation that suspends the upper extremity from the axial skeleton and is a gliding or plane-style synovial joint. The articulating surfaces that make up this joint vary from individual to individual, but are generally considered to be incongruent. The passive restraints of the joint include the thin, generally weak joint capsule that is strengthened superiorly and inferiorly by capsular ligaments. The AC joint is also supported by 2 extracapsular ligaments, the coricoclavicular and acromioclavicular ligaments. The coricoclavicular ligament is composed of 2 ligaments, the more medially located conoid and more laterally located trapezoid ligaments. The combined ligament runs from the coracoid process to the underside of the clavicle near the AC joint and provides horizontal stability to prevent superior dislocation. However, its most crucial role is in producing the longitudinal rotation of the clavicle necessary for full range of motion during elevation of the upper extremity. The acromioclavicular ligament provides the primary restraint to posterior translation and posterior axial rotation at the AC joint. There are 2 primary muscles that play a role in active stabilization at this joint. The first is the trapezius that inserts on the lateral third of the posterior border of the clavicle and medial acromion, and the second is the deltoid that originates from the anterior border of the lateral third of the clavicle and lateral border of the acromion. Other muscles that act on the upper extremity and attach on the clavicle are the sternocleidomastoid and the clavicular head of the pec major. These muscles should be assessed during evaluation of the AC joint and with suspected upper extremity pathology. The AC joint also contains an intra-articular fibrocartilaginous disc that serves to increase congruency of articulating surfaces by linking the hyaline cartilage-covered surfaces of the acromion and the clavicle. Motion of the upper extremity requires motion of each joint of the shoulder complex. Scapulothoracic motion is a combination of coupled motion occurring at both the AC and SC joints. Motion at the AC joint typically occurs around axes oriented in the plane of the scapula and results in conjunction with movement of the scapula as can be seen in the video. The closed-packed position of the AC joint occurs when the glenohumeral joint is abducted to 90 degrees. The open-packed position is undetermined but generally considered to be when the arm is resting by your side. The primary function of the AC joint is to allow the scapula additional range of motion as it moves on the thorax. It allows for adjustments of the scapula outside the initial plane in order to follow the changing shape of the thorax as the arm movement occurs. It also allows for transmission of forces from the upper extremity to the axial skeleton via the clavicle. The AC joint is extremely susceptible to both trauma and degenerative changes. This is due to its small and incongruent surfaces that result in large force distribution per unit area.
The following are 3 pathological processes that can occur at the AC joint. Osteoarthritis is a degenerative change that is common from the 2nd decade of life onward, and results from a narrowing of the joint space by the 6th decade. However, this video will focus on ligamentous sprains and tears, since they are 2 pathologies physical therapists will most commonly encounter in practice. Common injuries of the AC joint include sprains and tears of the associated ligaments. For this reason, these types of injuries are often referred to as shoulder separations. This is not to be confused with shoulder dislocations. The Rockwood classification system displays a spectrum of AC joint injuries. This ranges from sprains and ligament tears to very rare injuries such as the inferior displacement of the distal clavicle. Sprains. Sprains are classified as a type 1 injury under the Rockwood system. Type 1 injuries consist of a sprain of the AC joint without the tear of either the acromioclavicular or corticoclavicular ligaments. Tears. Type 2 injuries consist of a tear of the acromioclavicular ligament but not of the corticoclavicular ligament. Type 3 injuries occur when both the acromioclavicular and the corticoclavicular ligaments have sustained tears. Type 4 injuries consist of tears of both the acromioclavicular and corticoclavicular ligaments with additional posterior displacement of the clavicle. Type 5 injuries occur when both the acromioclavicular and corticoclavicular ligaments happen with 100% displacement of the clavicle compared to the unaffected side. Lastly, type 6 injuries consist of tears of both the acromioclavicular and corticoclavicular ligaments, accompanied by inferior displacement of the clavicle into the subcoracoid space. Imaging is used to help diagnose AC joint injuries. Radiographs are the first type of imaging ordered, which help determine the osseous details of the acromion and the clavicle. In severe injuries, MRI or CTs may be ordered to help determine if the surrounding structures sustain injury. Ultrasound can be used as well to assess the rotator cuff muscles. Imaging in conjunction with a full evaluation, including a history, help diagnose AC joint injuries.
The following is a case study example of a patient with an AC joint pathology. Jacob is a 24-year-old male who presents to your clinic following a medical diagnosis of a right shoulder separation, type 3. Jacob tells you that he was riding his bike with friends this past weekend, as he usually does, when he went off a jump and landed short. This caused him to flip over his handlebars, landing on an outstretched arm. Jacob was unable to continue riding his bike and noticed a deformity that he reported as a big bump on the top of his shoulder. Jacob's friends took him to the emergency room where he received a sling and an x-ray. The x-ray revealed no fracture had occurred, so Jacob was referred to physical therapy.
It is particularly important to ask the patient about the mechanism of injury, as it can help the clinician focus their evaluation. A fall on the tip of the shoulder or on an outstretched arm are the most common mechanisms for injury for the AC joint.
Objective findings revealed Jacob is very tender to localized palpation over the right AC joint. There is notable swelling in the area with significant motion and strength loss secondary to pain and muscle guarding.
An evaluation of a patient with suspect AC joint injury should include all the normal components of a PT evaluation, but special attention should be given to the following. Observation and visual inspection of the affected upper extremity. The therapist should observe symmetry between the affected and unaffected side, check for any deformities, swelling, or bruising, as well as posture of the bilateral shoulders, scapula, and clavicles. Clearing test of adjacent joints. Neurological screen if indicated. Range of motion of the shoulder. As with any evaluation, a therapist should compare active and passive range of motion on both sides, taking measurements where impairments exist. Patients that have sustained injuries are likely to exhibit pain at end ranges of active motion, especially with horizontal adduction and elevation of the arm. Muscle length assessment. Combined movements assessment. Resisted test and special test. Accessory AC joint motion. It is likely that this will be very painful for the patient. Hypermobility suggests AC joint pathology. Palpation of the entire shoulder girdle complex. The therapist should pay special attention to the AC joint positioning, focal tenderness, spasm, or tenderness of the deltoid and trapezius, as well as sternoclavicular joint position, which may be altered with AC joint pathology. The therapist may defer palpation if patient presents with high clinical irritability. Special test. A positive on the following special tests suggests AC joint injury: cross-body adduction test, O'Brien's test, and the AC shear test. Differential diagnoses. Other diagnoses to consider with these patients include fractures. fractures can be of the medial or distal clavicle, the acromion process, or the coracoid process. It is also important to consider rotator cuff tears.
Jacob's impairments and limitations include pain, swelling, impaired range of motion, strength, joint play, posture, and function.
Prognosis. Patients who sustain type 1 or 2 injuries have a good prognosis and are able to return to full function within 3 weeks, or sometimes even sooner. Patients with a type 3 injury who are treated conservatively with physical therapy, after 6 to 12 weeks are able to return to full function. Patients may experience shoulder impingement, neurovascular symptoms, or muscle fatigue. Patients who sustain a type 4 injury or higher must be treated surgically before rehabilitation, and prognosis depends on healing and progression of physical therapy.
Goals for Jacob include pain and inflammation reduction and normalization of both joint range of motion and shoulder strength. Shoulder alignment, muscle length, upper limb proprioception, biomechanics, and sport-specific requirements should continue to be assessed throughout and treated as necessary.
Treatment. PG treatment for a patient like Jacob who sustained a type 3 injury may look as follows. During initial phases of healing, patients should continue wearing a sling. Pain control should be a priority, and PTs can help lead patients into selective gentle stretches and strengthening exercises. 2 weeks post-injury, patients should present with decreased tenderness to palpation. They should be led to higher intensity strengthening exercises and be helped to gradually return to normal activity with some restrictions. 6 weeks post-injury, full pain-free shoulder range of motion should be observed, and patients can be cleared to return to regular activity with a home exercise plan to continue strengthening. The actual incidence of AC joint injuries is not known and most likely is underestimated because many do not seek medical attention for it. Therefore, a good portion go undiagnosed and untreated. However, it is believed that AC joint injuries account for 40 to 50% of shoulder injuries in athletes. Sports conducive to AC joint injuries include football, hockey, and rugby. Additionally, this type of injury is seen more in males than females and is likely to happen in younger patients between the ages of 10 and 20. Outcome measures. This is done primarily by patient self-report and include the following: the UCLA Shoulder Scale, the Simple Shoulder Test, Shoulder Pain and Disability Index, disabilities of the arm, shoulder, and hand.